to introduce to you Dr. Andria Ford. Dr. Ford is a professor of neurology and radiology at WashU Medicine with a subspecialty in vascular neurology. She also has a master's of science in clinical investigation. Dr. Ford specializes in stroke in the young adult population, in neurological complications of sickle cell disease, in inherited small vessel disease, and also vascular dementia. She also cares for stroke patients in the emergency department, in the inpatient stroke service at Barnes-Jewish, and in the BJC WashU Med telestroke program and the outpatient stroke center at WashU Med. In other words, she's an active practitioner serving this community. She's the director of the section of stroke and cerebrovascular disease in the Department of Neurology at WashU Med. So you see, we have just a top expert in neurology and in stroke. And thank you for being here, Dr. Ford. I will turn it over to you.
All right. Well, thank you so much, Nancy. And thanks, Sarah, for this invitation to speak with you all today. This is a really exciting seminar series that's been going on for some time now. So I'm honored to be able to join and share some of my knowledge and work with you all. So as mentioned, I am a stroke neurologist. I'm not, I do most of my time is devoted to treating and thinking about stroke. So I will see if I can advance. Okay, there we go. Here are my disclosures. Most of the research I'll share today is supported by the NIH through the NHLBI and the NINDS. So here are some objectives for our talk today. We will talk about how we can think about the aging brain with respect to stroke and cerebrovascular disease, kind of get an understanding of what is vascular dementia and what are the real world consequences of that. And then a little bit of science. We'll talk about how an inherited disease like sickle cell anemia can provide a model for the aging brain and give you all an idea of what is, you might have heard of this term, brain age or brain age gap. So kind of go into that with regard to sickle cell anemia. And then just finish up with what opportunities arise from this work. So I'm going to start out with just some basics about stroke to get us in the mindset of what a stroke is, because then that will translate into what a silent stroke is. And so stroke occurs because of a lack of oxygenated blood to part of the brain that is, let me turn on my pointer here so it's a little more obvious. So we're kind of looking here at an artery in the brain, and you have a sudden blockage in that artery, either because there's plaque sitting there in that artery, or there's a clot that travels from the heart or somewhere else in the body up to the brain. And so that prevents the oxygenated blood from getting to the brain. That that blood vessel supplies that part of the brain. So of course, this leads to injury of that brain tissue and death of those brain cells. And then that causes stroke symptoms. Now that type of stroke is the most common type of stroke. It's called an ischemic stroke, where we have a loss of blood flow and oxygen to the brain. But a small group of strokes are the hemorrhagic strokes, and that is due to a breaking of the small blood vessel and bleeding into the brain and injuring the brain that way. So strokes occur about 800,000 times per year in the United States. About 140,000 will result in death. And it is the fourth leading cause of death in the United States. And it remains the leading cause of disability, which I think is probably the most important point as far as why strokes can be so devastating, because they take away our independence and our quality of life. So some of the work I do is focused on brain imaging, often CT or MRI scans. And so just to give you a sense of what we're looking at when someone comes in with a stroke into our emergency room, this is what we hope to see as a normal head CT. And these are like the fluid spaces in the brain. This is the right side, this is the left side, and this is the front, and this is the back. And so we like to see these normal fluid spaces and like a symmetry in both sides of the brain. And these are just different slices that you're seeing. But if someone were to have a stroke on the left side of the brain, again, these images are flipped in the way we look at them, then we see a large area of darkness here on this head CT, and that is showing us that someone has already had a stroke on the pretty large stroke on the left side of their brain. And this would cause right-sided weakness and cause aphasia, which is an inability to get your words out or understand words. So this type of stroke is quite common, and it's extremely disabling because it makes it really difficult to walk and to talk. And then this other smaller stroke can also be disabling, but smaller strokes tend to be less disabling. And this is a tiny or small little dark spot on the left side of the brain and the deep part of the brain called the thalamus. And so this is just another type of stroke. We have all different types of strokes from sizes and the symptoms they cause, and that certainly it means a lot for the patient because it determines what will be affected and how severely they will be affected. Now this is, oh, that is the wrong title I have here. This is a hemorrhagic stroke on the head CT, and this is a bleeding type of stroke. So this is a very large bleed in the right front part of the brain, and then in the left deep part of the brain over here. So these, not really what we're talking about today, but so you have a sense of the difference between a bleeding type of stroke and the loss of blood flow type of stroke or the ischemic stroke. So you may have heard of this. This is something that we're always trying to educate our family members on and our patients. And so this is called BFAST. It's an acronym to really remind us what are the main stroke symptoms that we're looking for when someone might be having a medical issue. So any issue with balance, vision changes like double vision or loss of vision, facial asymmetry, arm weakness, trouble getting the words out, all of these things are potentially stroke symptoms. And they tend to be sudden onset with stroke. And that tells us that this could be a stroke because it comes on all of a sudden. Sometimes people wake up with stroke symptoms, and that is just as urgent to get into the hospital. And the T at the end is probably the most important, which is that we only have a limited amount of time to treat patients because that tissue is dying once the stroke begins. So that's why we always tell people to call 911. Don't drive to the hospital because that will delay your care, because the ambulance will pre-alert the emergency room to make sure we're ready to go see the patient when the patient arrives. So what can we do about strokes? And these are strokes that have symptoms and patients come into the emergency room. There's two main, we call them acute treatments, and this the acute meaning the symptoms happened recently, and what we mean by that is within minutes to hours. Our time window for being able to deliver these treatments are 4.5 hours from the symptom onset for this top one, which is an IV medication. And then this is a procedure called thrombectomy. And this we have out to 24 hours. But regardless, earlier is better. So you would never wait to come in if you thought or someone or yourself could be having a stroke. So this is tenecteplase, which is the medication we tend to be giving now for patients who come in with stroke and have to meet the right criteria for that. And then thrombectomy may be indicated, which is a procedure to go into the blood vessel with a catheter, a tiny catheter, and pull out or suck out the clot that is sitting there in this blood vessel here. So this is a very critical blood vessel that supplies most of that hemisphere, in this case on the right side of the brain. And so it's been revolutionary to have the ability to perform these procedures and take out the blood clot. As long as it's done timely, it can help some people dramatically return to normal function and prevent them from going to a nursing home and being very disabled as they used to be before we had these procedures. So, we have our acute therapies, we have in the hospital care, figuring out why the stroke happened, what the risks are, making a plan to reduce those risks, and then coming back to the outpatient setting for continued education and ensuring those risks are being taken care of. And rehab is a huge part of recovery for and being able to get back closer back to normal after a stroke. And then this is getting more into kind of the purpose of this talk is thinking about age. So age, certainly has a dramatic, important relationship with many diseases. That with age, we see an increase in risk of diseases often, and not always, but often. And so stroke is certainly right up there with other age-related diseases, cardiovascular, malignancies, and so many others. But what we see here, this is just a study that was done, and interestingly, this Framingham Heart Studies actually began enrolling patients back in the 1940s, but it has had new versions of the study until present day. But in this particular study, 5,000 participants with 40,000 years of follow-up, and on the left we have women, on the right we have men, and it's just looking at that relationship between age and stroke risk. So you can kind of look at the 10-year stroke risk, 20-year, 30-year, and lifetime stroke risk for women and men. And you see it starts already at an older age of 65. So we're really not even looking at younger adults here. I would say even for younger adults, which is an area of interest of mine, it's the same age relationship where you see this very, 20-year-olds, very low risk of stroke. But if once you get closer to 40 and 50, you've really shot up with an increased risk. And then this takes it even further above age 65. And what this study was kind of comparing stroke risk to was compared to the risk of dementia. And they found that the risk of stroke was actually somewhat higher than the risk of dementia, depending, I guess, in the men is higher than the risk of dementia. So another age-related finding here is that, and this is looking at, again, the age and the risk of stroke, but stratified by blood pressure. So there's this very strong relationship between having high blood pressure in mid-adulthood and stroke risk. And so you can see that those with the highest blood pressures in red certainly had the highest risk, and so on down with lower to normal blood pressure. But you still see that age relationship across all of these levels of high blood pressure. Okay, so now we want to talk about something called silent strokes, and there's different names, and I've kind of started to list some of the names. I'll try to give some understanding of why we have these names, but a lot of them mean the same thing. So a silent stroke is really similar to what we were just talking about, except that they don't have symptoms. So you don't suddenly have a symptom, but you do have an area of injury in the brain. So we know that now by the advanced imaging that we have. We can follow these and track them over time and see that we see an area of ischemic stroke that was not associated with any presentation to the hospital or other symptoms. They tend to be small. They tend to be in the white matter, which is the deep part of the brain. So it's not what looks white here. It's actually the deep, darker gray color is that white matter, with the gray matter being along the edges with the cortex. So these little white spots here are tiny silent strokes, and then you can see that they can accumulate and really take up a lot of the white matter over time. And so we just see this varying degree from very minimal burden of these silent strokes to very significant burden. So these have different names, and I'll try to stick with one name throughout as much as possible throughout, so not to cause confusion. But you might hear about these in the future if you or someone gets a brain MRI. There's terms called small vessel disease, white matter disease, microangiopathy, small vessel ischemia. So these all pretty much mean the same thing. And it means that and they'll qualify them with mild, moderate, severe, and they tend to, increase, accumulate over time. And there are, certainly we know something about why this happens, but there's still a lot left to understand. So, and this brings us to what is vascular dementia, because that is really what those imaging findings are linked to, and why we think they're important is because they actually are associated with cognitive impairment. And so this would have been something I would have learned about or heard about in medical school, something called Binswanger's disease. And this was a condition first described in 1894 by Dr. Binswanger, and he noticed, again, this is a time we had no MRI and no CT scan. So he noticed that patients who had dementia symptoms, but did not have the typical pathology of Alzheimer's. So looking at brains of patients who had cognitive impairment, but who didn't have Alzheimer's features based on, these pathological changes that are shown here on the right. So this was quite an important discovery, but really not easily translated or followed scientifically until the advent of imaging and advanced imaging, where we could see a little bit more about how these lesions were developing, because it's, most people weren't getting autopsies. So the different terms, as I mentioned, there's different terms for the white matter disease that you see on imaging. The cognitive terms, which is the kind of that manifestation of those spots in the brain, are also we have also several terms. So the one we'll use today is vascular dementia, but you'll also hear vascular cognitive impairment, or this is the newer, trendier term called VCID, which is vascular contributions to cognitive impairment and dementia. So again, they all mean the same thing, and that's that the cognitive problems are likely due to the vascular changes and the silent strokes. It's the second most common cause of dementia, and some suggest that the mixed dementia with having Alzheimer's features and vascular dementia may become a leading cause for dementia. So we won't get into this too much, but there are certainly in a neuropathology. So we see these imaging changes on MRI, but if you look under the microscope at someone who's had a brain biopsy or someone who has died and has dementia, then you can see these certain findings. And this shows that damage to those, typically the very small pathways to our blood vessels in the brain, which we refer to as arterioles. And so you can see here that there's a thickening of the tiny arteriole in the brain. Importantly, there is a loss of reactivity in these brain blood vessels, and that's very important because in a normal situation without these changes, your brain blood vessels can dilate and constrict, and that allows us to regulate the blood flow in the brain to stay very steady. So when we have change in position, or we stand up or lie down and undergo certain stressors, then our brain can actually maintain its blood flow. But we lose that ability as the damage from like high blood pressure or age occurs. Then we lose that reactivity, and that's likely can help cause more silent strokes, can provoke strokes, because we can't regulate that blood flow in the brain. So this is getting into some of the science and what's evolved over probably 30 or more, 40 to 50 years with MRI techniques. So now we have really improved our ability to see different features of vascular dementia on these advanced MRI sequences. And so we won't go through all of these. I will say that, one of these is kind of what we were looking at before, which the terms are called white matter hyperintensity and white matter lesions. This is something that is probably one of the first imaging findings people notice that would be progressive. But these other findings of small bleeds in the brain, enlarged kind of veins that help get rid of waste in the brain. There's many other interesting findings that may give us insight into the into the pathophysiology of how this is causing cognitive impairment. And this brain MRI is actually, I do these imaging studies and we do cognitive testing. So I recruited my mother for one of these studies several years ago. And I knew she had had longstanding high blood pressure that wasn't treated for many years. We just didn't know she had it. So she had a lot of these findings on her brain MRI. And so she had a lacunar stroke. And one thing I haven't mentioned yet is atrophy. So there's a shrinking of the brain, deep in the brain, and then these tiny bleeds in the brain, which are these dark spots here. So we can follow participants over time and see how things are changing in the brain. These are just written out in a list, all these different imaging findings. And importantly, what's kind of important to take away is that some of these imaging findings are good at predicting who's going to progress with cognitive problems and become, and have dementia over time, whereas other sequences, other of these MRI findings aren't very predictive, or they're hard to quantify. So that's how as a science, we help, we use these sequences and try to determine which ones are useful to understand what we care about, which is the cognitive consequences, and not just cognitive. Sometimes people will have motor or balance symptoms, but we really want to see how these can be predictive. So how do these silent strokes and imaging findings manifest? So, what do we really care about? These imaging findings are kind of interesting to look at, but really we care about the patients. We care about how it's affecting us. So some of us, myself included, may wonder if we are already there or might be soon when we when we catch ourselves saying these things or hear these things from family members. So I'm always asking, remind me of your name again. I'm horrible with names. It's just an excuse. And I may have had that problem for some time, but is it getting worse? That's always in the back of my head. Am I having more trouble retrieving that name of that person? I should really know. What is the word I'm looking for? Just losing things. Have you seen my keys? Getting lost, of course, if you're in the car driving around. Certainly there's some anxiety. I'm not sure I want to actually travel away from home for that long and be in an unfamiliar place. So all of these things with our everyday life bills, shopping, work, driving, social interaction. So this, when in my clinic, this is probably, I get two most common complaints, and this is one of them. It's really like that concern for memory issues and cognitive issues, not really functioning in a social setting or even at home in that way. They're worried that this may mean, first signs of dementia. And the other most common complaint I get is really balance. As people get older, their balance just isn't what they're used to having. They're worried about falls, understandably. So how do we think about these more concretely in a way that we can study for these real world consequences? So under the heading of cognition and loss of independence, we have many cognitive tests where we can measure cognitive dysfunction in different domains. So there's quite a lot of great work in this area. I would say most of this work would have been done over the past decades in the field of Alzheimer's and in some of the other neurodegenerative diseases like Parkinson's, even before this was a focus for vascular dementia. So I think all the focus for cerebrovascular disease is on acute stroke and how to recover from that, but not as much on the side of just silent strokes and progression and how that can impact cognition. So we think about executive functioning. So this is our ability to plan out some tasks that we need to do, maybe a multi-step task, plan our day, organize our day. Processing speed is just something that has multiple steps to it. Can I actually complete the task and stay attentive to it? Can I keep attending to what I'm supposed to do to complete it? And then there's working memory, our ability to remember something, remember what we had for lunch, remember what someone just told us, versus our crystallized memory, which is something that happened a long time ago, may be less affected by these changes in our white matter. Other things like mood changes, irritability, personality changes, gait disturbance. So with vascular dementia, while it is absolutely impacting cognition and putting us at risk for a dementia, which is a severe form of cognitive impairment, it can affect our other structures in the brain, such as the cerebellum, which controls our our ability to walk safely and not.
I'm listening to a.
Okay, let's see. So importantly, we think about how do these vascular changes interact with other pathologies like Alzheimer's dementia. So I think that's over the past probably 10 years, this has been a new focus and really important because it's now we know that if someone is vulnerable to having Alzheimer's dementia, and they also have these vascular changes, they're likely to get Alzheimer's dementia earlier, or the effects. It could be the effects of both factors on their brain, causing an earlier onset of the memory and cognitive problems. So all of these, we have ways to measure them. We have different cognitive batteries, and it depends on the study and what your goals are, which ones you might choose to do for your, depending on your research question. So these are all importantly, in fact, impacting our quality of life, things like driving and our independence. So I'm going to just segue into the kind of second part of what I want to talk about today, and that is getting into a little bit more of the science with regard to how an inherited disease like sickle cell anemia could provide a model for the aging brain, and what is brain age and brain age gap, and then kind of putting it all together. So one challenge of studying what I just talked about, which is classic vascular dementia, where you have these changes in the brain. And again, I didn't talk much about this, but they're usually due to high blood pressure, due to age, probably some genetic factors that we don't fully understand yet, but high cholesterol, smoking, diabetes. So all of these factors that influence the tiny blood vessels in the brain can lead to these changes. But the difficulty in studying it and really understanding it has to do with the rate of progression. So in some people, you will see a pretty fast rate of progression, but in many you won't. So that many of our studies that we do are over about 5 years, and we'll actually follow participants only for about 3 years. And so I just showed a couple of people who were in our studies, and you can look at their baseline MRI and you can look at their 3-year follow-up MRI. And so what we're looking at here are these little white spots in the brain, and this is just 2 slices. So you can compare this one to this one and this one to this one, and by my eye, there's some changes here. And so this, you may be able to quantify that change or that rate of progression. And here's another more severe case where you can look at their baseline and then their follow-up and then their baseline and follow-up. And just the difficulty here is that you're going to have kind of a slow rate of progression. So that can be hard because we want to find treatments, find disease mechanisms that alter that progression, and we want to find things that will stop that progression, like a blood pressure medication, and so that can be challenging if you're really not able to measure that progression over time. So that leads us to maybe looking at other diseases. So here are several what we call monogenic microvasculopathies. So as you all know, there's just thousands of genetic diseases. So what I have shown here is a short list of those genetic diseases that cause a problem of the tiny blood vessels in the brain. So that's what this name is for. And I highlighted the ones that we are studying here in my lab: sickle cell disease and CADASIL, and this other very rare disease called RVCL. And these can give us insight into the more common vascular dementia because these cause more rapid or earlier onset of these small vessel vascular changes. So there's pros and cons of, using these as a model for a more common disease like vascular dementia. Cons are obvious. We're not studying the same disease. We don't know if the findings we see can really be extrapolated to the more common disease if we study this rare disease. But as I already mentioned, we can maybe learn things if the rate of progression is faster. We might see greater disease severity. So these disease mechanisms may be harder to miss if they're more overt or obvious. These patients may be following with us because of their disease. And so it may be easier to, or they may be more likely to be getting imaging and being followed than patients who are people who are in the community and not really knowing there's any, problem at all with their brain. So, this is an example. I'm not really going to talk more about this rare disease, but I did want to show it because it's quite devastating and it begins in a young adult age. And you can see progression. I'm going to show you this panel here and then this panel here and a 38-year-old woman and a 53-year-old man. And you can really see, I think you'll be able to see these white spots in the brain develop over months at a time. In this case, this was over 1 year. And in this case, it's over only 6 months. You can see all of these little white spots have progressed since the image before 6 months prior. So this is just an example of how you can capture that disease progression over a shorter timeline. And it may be allow you to study it and also study the effects on cognition, such as in this disease. So again, why would we want to, use this study of rare disease like sickle cell anemia for another more common? So these are 3 possible reasons, and this is kind of a lot of, medical, clinical research type of language here, but I'm going to kind of explain a little more about why we would want to find a surrogate endpoint and what a surrogate endpoint is. And I won't really go into these other 2 because of time. But importantly, these imaging markers, or they can be fluid markers, these measures that we can quantify and easily obtain that are ideally non-invasive tests that we can do, they can be very helpful to substitute for a clinical outcome that can be hard to measure, or maybe we need to get an earlier measure of something, like if someone is going to die from something, then we want to be able to measure its progression before that. So this is just kind of a definition of what a surrogate endpoint is. And it's a measurable factor used as a substitute for clinical outcomes such as disease progression, survival, or quality of life. And changes in the surrogate endpoint should reflect changes in the clinical outcome. So you should ideally see this 1-to-1 correlation between your MET marker and that clinical effect. And so these are examples here. Blood pressure, as I already told you, you can see with increasing blood pressure, your stroke risk increases. So it can be a surrogate, just measuring a simple blood pressure measurement can be a surrogate endpoint for cardiovascular events like heart attacks and stroke. Tumor size could be a surrogate for cancer survival. Viral load would be, this is how much of this HIV virus do you have? So the amount of that is a surrogate for the progression in HIV. So these are just examples. But why are they used? They can help accelerate evaluation of new treatments. They can help reduce the sample size needed for a clinical trial and potentially lower the cost of trials by reduction in sample size or by doing a simpler, less expensive measurement. So again, I'm kind of get into how with sickle cell disease, we can think about these surrogate endpoints with regard to brain imaging. So I'll kind of give you a crash course on sickle cell disease, but it's a fairly straightforward mutation of the beta globin gene, which is important for our hemoglobin production. And so normally we have hemoglobin A, but with this point mutation, it becomes what's called hemoglobin S. And so this is what the hemoglobin A molecules should look like in our blood. And this is in our red blood cells. And so it helps, this is very important that this hemoglobin carries the oxygen molecule. So this is what's taking the oxygen to all of our tissues. And what happens when we convert it to the hemoglobin S, it causes a polymerization whenever there's low oxygen in the blood. So then we get these chains of these hemoglobin molecules, and that actually cause this appearance to the red blood cell. So this would be a normal red blood cell that's kind of a disc shape with this kind of caved in area. But instead, the red cell becomes dysmorphic and then eventually becomes this called sickle shape. And this is very dysfunctional, and this leads to breaking of that red blood cell, and that causes anemia. So you don't have as much blood, and then it causes many other downstream effects. So multi-organ effects, and this was another graphic that shows that it doesn't just affect the brain, which is what we're interested in, but it affects many other organs. It causes pain from kind of like a stroke or infarction of the bone itself, which is a blockage of blood in the bone, which causes pain, and many other organs are affected. This is showing the silent strokes that it can cause in the brain, as well as very dramatic effects with clinical strokes. And here's just a picture from something called the sickle cell stroll. Because it's a familial disease, then families come out to support research and kind of their community with this illness in their annual sickle cell stroll. And everyone makes these very cool t-shirts for their family, and it's an important annual event. So it's been known that in sickle cell disease that there is abnormal brain development. They have this genetic mutation from birth. So there's a problem getting oxygenated blood to their brain at a very young age. So what this is showing is that the gray matter volume is different in children with sickle cell disease compared to healthy children. So you can see that normal growth of the gray matter in healthy children is really not there if you have sickle cell disease. And then the same thing for the white matter volume, that's the deep structures of the brain. We're seeing a lower white matter volume that has trouble catching up to where the white matter volume of the healthy children. This is showing that they tend to have these silent strokes at a very young age. Even a quarter of children by age 6 will have one of these. This SCI, is called a silent cerebral infarct, but same thing as a silent stroke. And they tend to have them increasingly through adulthood, and this likely continues to increase over age. And why do we care about those little spots in the brain? Well, they have been associated with cognitive impairment, and these studies are taken from children actually with sickle cell disease compared to controls. And what it's showing us is in these 4 different groups of children, what is happening with the full scale IQ. So in controls, we have our full scale IQ around 90, and then we get a lower IQ for children with sickle cell disease. And then we see another drop in full scale IQ with patients who have sickle cell disease and have a silent stroke in their brain, and then further decrement in cognition with sickle cell disease who've had a symptomatic stroke. So this is very importantly, there is difficulty in progressing in school. So there's grade retention. There is trouble in adulthood with maintaining employment, and this is largely associated with their cognitive abilities and other medical factors as well. So we did a study in adults with sickle cell disease, and we really there's actually not, this is one field where there's actually more studies in children than in adults. So actually going into the field of adults with sickle cell disease was interesting, because most of what we know about sickle cell disease in the brain was in children, and there were several clinical trials testing therapies like transfusions and other medications in children. So we wanted to learn more about adults with sickle cell disease, if their brain imaging findings were abnormal and if they had any cognitive impairment. So this was a cohort we had of controls, and they were race matched. These are all African Americans from mostly from St. Louis with sickle cell anemia or controls. We tried to recruit from the clinic our controls, so we would have somewhat matching for other like socioeconomic status, but we were not successful at recruiting completely from the clinic, from like friends or partners of the patients. So we also recruited in other realms as well. So importantly, when we get into brain age gap, this is all based on machine learning and a deep learning model, which I won't get into the technical aspects of this, but it uses a T1 map, which is a very standard brain MRI image. That is, anyone who gets an MRI is probably going to get this image, although this is a very high resolution version of that. And it trained, this model took 14,000 brain T1 images, and it trained itself to understand and be able to spit out the patient's chronological age. So it correlated the chronological age with this T1 map. So you trained on that, and then you can then validate it and give it other T1 maps and see how good is it at coming up with that patient's actual age. So this again was brain age was trained on this model, and then the brain age gap is when you have someone who their brain age as calculated from this map is not fitting with their actual chronological age. So it's just simply a subtraction of the estimated biological age using this T1 app, subtracting minus the participant's chronological age. So a positive brain age gap would indicate that the patient's estimated brain age is older than the chronological age, while negative brain age gap would indicate a younger estimated age. So what we found in sickle cell anemia adults and controls is that there was an so their estimated brain age was older than their chronological age. And so we weren't very surprised about this with regard to the adults with sickle cell anemia, because atrophy, shrinking of the brain has been shown before. But what we weren't expecting is this increase with the controls. Is why are the control population appearing to have older estimated brain ages? So that was part of this kind of a secondary analysis of this study, was not just understanding the effects of sickle cell anemia, but looking into the controls as well. So what we find here, again, this is kind of showing the same thing, but that we have an increased brain age gap, suggesting older appearing brains in the sickle cell anemia group compared to the controls. This is what it looks like on the T1 maps. Again, we don't know, because it's AI deep learning model. We just give the model, this computer model, our T1 images. We don't know what features of this map it's using to give us our estimated brain age, but we can look at it. And certainly when you look at the T1 map and you see the differences in a patient with a low brain age gap and a high brain age gap, you start to see, well, it does appear to be some shrinking here. So this is a 21-year-old control patient. This is a 29-year-old control patient. The patient's old, or the participant is older, so we expect some shrinking of the brain, and this is certainly something we expect to some degree, but we wouldn't expect really a brain a larger brain age gap, and you start to see some atrophy here, shrinking these widened fluid spaces. And so that's maybe what is going into that estimated brain age. And then same thing with the sickle cell anemia group, that you can look at just examples of patients who had higher brain age gap. This is an example of one who had 15 years of a difference between this is their estimated brain age and their actual age. And you can see, this looks a little bit less healthy than this brain, although it's very hard for me to tell that. Whereas you go to a very high brain age gap, and this is a brain age gap of 32 years. So this 39-year-old man with sickle cell anemia, his estimated brain age was 71. But you see here, there's just a huge amount of volume loss and shrinking of the brain. And that could be from over the years of having the disease. So one thing we wanted to look at is not just the impact of disease, which we know we have different disease markers for sickle cell disease that could be driving this finding of this increased brain age, but we wanted to look at the impact of socioeconomic status. So this is like using the area deprivation index which is based on your address. So person's address, you can get this area deprivation index, with higher being more deprivation or more poverty. And you can see in the sickle cell anemia group that each quartile of brain age had a kind of a similar area deprivation index. And you can see these are really high deprivations. Our medians are 85 to almost 90% here. And we're getting similar across all the quartiles of brain age, you have similar deprivation. But in the controls, we were really seeing that the higher deprivation, the higher ADIs, was associated with the larger brain age gap. So that socioeconomic status piece may be driving either premature aging of the brain, although it could be development of the brain. It could have occurred before we measured them, that their brain age was already affected based on brain development. And I think I'm going to skip over this, so we just have a few more minutes. But in this case, we were looking at, again, getting back to a surrogate endpoint, we wanted to know which markers, brain imaging markers, would be good at predicting or associating with our cognitive impairment. In this case, we were looking at executive function. And we found that what was predictive for controls was not necessarily the best predictor for patients with sickle cell anemia. So in our control group, which are the yellow dots here, the brain age gap strongly correlated here with the executive scores. But in the sickle cell anemia patients, it was just a kind of a non-significant correlation. Whereas using another metric, which I haven't really gone into, but this is more of a metric of how much ischemia or lack of blood flow has occurred in the brain. This metric was much better in the sickle cell anemia group to predict executive composite. So what would be a good surrogate endpoint for our control group, which is in this case, I think brain age gap, was not the best one for the sickle cell anemia group, although it was somewhat predictive. So we were looking in this study at mediators of economic deprivation on cognitive performance. So brain age gap mediated that association. And then in sickle cell anemia, we looked at both brain age gap and found them both imaging markers to be predictive of cognitive performance, or mediators of the disease on cognitive performance. All right, I'm just going to skip over this. And I talked about already why we might need surrogate endpoints, and it may help with reduction of sample sizes needed in clinical trials. I'm just going to skip over this and then talk about what are the opportunities from this work. Well, importantly, I think our goal is to prevent, or at least slow, the progression of vascular dementia. We talked about how common strokes are and how they are age-related. I haven't talked as much about how common silent strokes are, but and I should have done that, but they are more common than having a symptomatic stroke. It's even more common to have silent strokes. We're also interested in prevention or slowing of Alzheimer's dementia, and understanding the social underpinnings of this age-related disease. So we just touched on that with the area deprivation index in a young adult. One thing I didn't really mention about that sickle cell disease cohort and the controls, they were in their 30s. I think the median age was 25 to 30. So you can really get insights in that chronic disease from a very young adult population, and looking at that, the impact of the area deprivation index. So this is, another large study showing that relationship between high blood pressure and incidence of dementia. So the higher the blood pressure, the more likely someone is to get dementia. And so this really provides a potential area for intervention, because we know we have plenty of blood pressure medications that are effective in reducing blood pressure, but do they really help prevent dementia? So this is quite a busy slide, but many trials have begun looking into this. If you do institute earlier blood pressure therapies, can you prevent dementia? And I think the answer is, sorry to say prevent. I think yes, they are helping. I think this study probably, again, it's a very busy. This is showing different classes of blood pressure medications, and the question was, well, which class of blood pressure medicines is better? We have all these medications. Which one is most likely to, prevent incidence of dementia? And what they found, it really wasn't a class effect. It was really that all of them in combination appeared to have an effect. So lowering the blood pressure was more important than which blood pressure agent you used. And then, do we have an opportunity here to look at the interaction of vascular dementia with Alzheimer's dementia and work on prevention or delay of both? And I think what these studies are autopsy studies, really showing how common vascular dementia is, not as common as Alzheimer's dementia, but then how common mixed pathologies are. So if you look at the brains of people with dementia, you're very likely to see some vascular changes and some Alzheimer's or amyloid changes. And this was another autopsy study. And this was getting at how, again, using area deprivation index, and there's plenty of other ways to measure this, but how in this case, this really had an effect. If you looked at those who are most deprived of older adults, and these were unimpaired, non-demented adults initially, you can see there's a widening of the gap between those with economic deprivation compared to those without. This was a longitudinal study looking at cognitive impairment. So you see a worsening of cognitive impairment over time in those older adults with economic deprivation. And here's another example of that. These are two different cognitive tests. So these are my conclusions here, which is that vascular dementia is the second leading cause of dementia. The implications for these vascular contributions at a societal level are large. We've talked about how they impact our independence and our quality of life. And there's an opportunity, because a lot of these risk factors are, can be controlled, can be treated, as long as we intervene early enough and can provide stabilizing or prevention strategies. Health disparities, we know these are impacting probably from childhood age, affecting brain development and then brain aging. And then of course, studying monogenic diseases or rare diseases can be important to really hone in on the disease mechanisms and ways that we can, make clinical trials more achievable. So that, I think, is my last here. My acknowledgements. I have so many people to thank that I work with, from the clinical stroke work we do, and then also on the research side. We have a wonderful team, and I get to work with Children's Hospital as well with our sickle cell disease group. So I really have a great job and work with some pretty amazing people. So thanks, and I guess I probably just have a couple minutes for questions.
Great. Thank you so much, Dr. Ford. That was so packed with great information, and we're so grateful to you for sharing your time and your expertise with us. We'll take a couple questions. Thank you for saving some time for that. I'm going to also put a survey in the chat. And we've got two questions in the chat, and then if folks want to continue to add questions in the chat or raise your hands, I see we've got one hand raised. We can do that. The first question from Stanley, from Stanley Burge, what are the pathologic correlates of economic deprivation and brain aging?
Really great question. I think as far as the actual pathology of the brain, I think it comes back to how we've defined them so far. So, vascular changes are certainly, we can identify those and say this is due to high blood pressure, this is due to diabetes, maybe due to age. But the question is, how is the economic deprivation kind of hastening the effects of those medical issues, or bringing on those medical issues? Maybe it's just that you can't get your insulin, so it's untreated conditions. Certainly education surrounding how to treat medical conditions or to identify them to begin with. So that's a hard question. I think I appreciate that question, because I think we're not quite there to identifying unique pathological correlates to economic deprivation, more so the medical things that we know are occurring.
Thank you. We'll go to Dr. Carr in just a minute. I think this may be a question that a lot of people have. When a person calls 911, what information should be imparted to the dispatch related to a potential stroke?
Yeah, great. So we mostly want to know when the loved one was last known to be normal and their normal self. It can be when they went to bed the night before, or could be they've already woken up, they were normal, had their breakfast, and then something happened. So we really need that time, because that time, that clock is really important for us to know if it's safe and beneficial to give a medication. Also, their medications, if they're on any blood thinners or other recent surgeries, that's all important information that can be relayed by EMS. But if you have a way to get to the hospital and be there, we always really like to confirm with family and not just always rely on EMS, although often we do have to rely on EMS.
Thank you so much. Dr. Carr, do you want to unmute yourself?
Dr. Ford, that was an excellent lecture. Thank you so much for sharing that. A lot going on. A couple quick questions, if we can squeeze them in. One is, with our MRI with 3D volumetrics, we get a qualitative measure of white matter disease. And is there a level that you feel comfortable attributing cognitive changes? We always have to look for comorbid conditions, Alzheimer's, but I mean, if you have a moderate to severe level, are you pretty comfortable attributing, cognitive decline to that? And the second is, are we going to get a quantitative measure of white matter disease at some point on our MRIs?
Yeah, I that's a really great question. Yeah, I think with brain volume, I had to skip over those slides, but it was true that for some cognitive metrics, our brain volume was really associating with some of the cognitive things we care about. I think it was processing speed. But we don't think of brain volume we think of it more with Alzheimer's as being more of especially gray matter volume and hippocampal volume being more predictive. So you're right, we're more focused on those lesions and the increase in that, and other like DTI metrics, that's the white matter microstructure. But I do think white matter volume is likely predictive. So and then the problem is with a given patient, I think we're still far off, because I don't think we can take that number and be like, this translates directly to the patient, because each patient, as you know more than I do, that they each have their cognitive baseline and their education level and all that they're bringing into that visit, and then you really want to see that change over time. So we need imaging metrics that kind of take into account that in some way, wherever they're beginning at, and looking at how is that individual going to change. So I don't think we're quite there yet. I think we're there. We're able to do research studies and get a better understanding, but getting the precision medicine that we're getting with Alzheimer's field. I don't think we're quite there with vascular dementia yet, but I do think we do need that white matter lesion burden metric. I'll email our radiologist today because we have good, even our own homegrown ways to quantify that. And there's other, I'm sure, commercially available. So yeah, we need to just add that. I think that would be helpful for people to have a sense of that volume of the lesions. Yeah, great point.
Thank you.
Any other questions? We have a lot of comments in the chat, a lot of thank yous and appreciation, Dr. Ford.
Well, thanks so much. Sorry, I tend to go way too long, and I did it as usual, even despite my efforts. So thank you so much for everyone's attention and great questions. I see, at what level of white matter disease do you use the word stroke with patients? Yeah, and I think that's when we use the word silent strokes unless they've had clinical symptoms of stroke. And so we just will, I think it doesn't matter too much. If I was worried someone might overreact to that word, maybe I wouldn't use that. But I think it is good to use silent strokes because they do have these cognitive effects and we want to prevent them. So, right.
Wonderful. Well, thank you so much. We appreciate everyone completing the survey. And then this recording will be available on our website. So if you enjoyed it, which I think many did and want to share it, it'll be available for you. And thank you so much, Dr. Ford. We really appreciate your great talk today.
Oh, awesome. Thanks, everyone.
Thank you. Bye-bye.
Bye.